Diagnostic errors, which are defined as incorrect, missed, or delayed diagnosis not made within an optimal window of opportunity, have been challenging to study in the acute setting for several reasons. There is a wide variability in operational definitions of diagnostic error. Former studies have used non-standardized and low-sensitivity data collection instruments, and the positive predictive value when measuring diagnostic errors from a random sample of patients is low. Recent studies have suggested that specific type of clinical events in the EHR or e-triggers may enrich a cohort with cases likely to have diagnostic error, thereby increasing the positive predictive value of diagnostic error. The purpose of this analysis was to estimate the prevalence of diagnostic error in the hospital setting. We achieved this by using a standardized validated chart review tool to ascertain diagnostic error in a stratified cohort of cases randomly selected by specific e-trigger events with variable hypothesized likelihoods of diagnostic error. Our population was defined as patients who were hospitalized on the general medicine service at a large academic medical center in Boston, Massachusetts from July of 2018 to March of 2020. We used a stratified random sampling to assemble a cohort of patients based on a priori selected e-triggers as it is shown in Table 1. Diagnostic error was ascertained independently by two clinician reviewers who conducted structured chart reviews using validated instruments, the SaferDX instrument and the Deer taxonomy, which we previously adopted for the acute care. All cases were adjudicated by reviewers until consensus was reached. Cases in which consensus was not attained were sent for tertiary review by an expert review panel to resolve all discrepancies. We calculated the prevalence of diagnostic error for each stratum, from which we calculated the unbiased prevalence estimate for the entire population and corresponding 95% confidence intervals. A total of 4,715 patients were hospitalized between July of 2018 to March of 2020 with a length of stays of less than 21 days. We randomly sampled 350 of these patients and excluded one patient who did not meet inclusion criteria. We found that diagnostic error prevalence in our sample showed a gradient effect going from a higher to a lower prevalence depending on which e-trigger was used to randomly sample each of the chosen subgroups. Patients who were transferred to the ICU after 24 hours of admission had the higher prevalence of diagnostic error of 51%, and patients who did not have any of the triggers had the lowest prevalence of 20.8%. We calculated the population unbiased estimate using a weighted average of each of the strata proportions, and we found that the prevalence of diagnostic error in our population was 22.69%, with a 95% confidence interval as low as 16.34% and as high as 29%. We also found that the prevalence of diagnostic error that actually caused harm was 6.66%. In Table 2, you can see some clinical examples of diagnostic error. We also determined that the three most common diagnoses associated with diagnostic error were respiratory failure or hypoxia, heart failure decompensation, and sepsis. These findings are important because they suggest a high prevalence of diagnostic error in the acute setting and highlight the importance of understanding cognitive and system factors that influence the diagnostic process to design and implement interventions to mitigate harm associated with diagnostic errors. Thank you.